blood in it. So just in case anybody gets nervous about that, I just want to forewarn you that I also want you guys to see sort of the unvarnished truth about what goes on in treating children with myocarditis. I also have a couple of videos that unfortunately will not play on this Mac, but we'll get through it, and I'll do some hand motions and body language to help explain what I'm talking about. Well, I want to first start with a story, and it's a story that actually I'm hearing repeated. Paul gives a very similar story to this patient that I took care of. So this is a real case. This is a patient I took care of a few years ago at Texas Children's Hospital. It's a 16-year-old boy who previously was healthy, strong, active, had lots of friends, was in baseball and basketball, sort of the prime of his life, had just gotten his driver's license. And then he fell ill, and he started complaining for several weeks of fatigue, didn't have the same energy that he used to have, some shortness of breath, some chest pains that he had never complained about before, even chest pain at rest. He noticed that he was requiring several pillows to sleep at night. He couldn't lie flat anymore and breathe comfortably, so he had to prop himself up just to be able to breathe comfortably at night. And some skipped heartbeats, some palpitations that he was experiencing that he hadn't experienced before. His parents took him to his family physician, explaining some of these symptoms. He had developed a cough as well, and sort of this low-grade fever that was off and on. His pediatrician was concerned that, well, maybe he has bronchitis. Prescribed some antibiotics, sent him on his way, and the kid really never got better. In fact, his symptoms seemed to progress and get worse. He went back to his doctor again. He listened to him. He thought he heard wheezing. This guy had never had asthma before, so he'd never wheezed before, so this was new. So his physician was thinking, well, maybe this is asthma, new onset asthma. So he prescribes him an inhaler, puts him on some steroids, tries to alleviate his symptoms. The kid goes home, continues to have the symptoms, and they continue to progress and get worse and not really respond to the therapies that the physician had prescribed. So his family had had enough, and they took him to the emergency room, concerned because he was actually getting sicker right in front of them. And in the emergency room at the outside hospital, they performed a chest x-ray when they heard the wheezing and the crackling noises in his chest. And what I've demonstrated here on this side, on the left, is a normal chest x-ray. This is the heart in the middle, the lungs on the side, the liver over here. And you can see how this contrasts quite a bit to my patient that I had in the ER. This patient's heart is markedly enlarged, dilated. So it's a dilated heart that we saw on chest x-ray. These lung fields, they're hazy. They're not as crisp and clean as these lung fields over here. This is fluid that's accumulating in the chest. So congestion, it's partly congestive heart failure that you hear about. So our patient it's not surprising that he was short of breath, that he was having chest pains, that he was having palpitations, because he's being affected this way. This is an EKG. This is another test, another tool that we use when we're trying to diagnose patients. This is what a normal EKG looks like. As you can see, each one of these little vultured spikes represents a heartbeat. And that's pretty regular, pretty organized. These spikes are pretty narrow and consistent throughout. And in my patient's EKG, as you can see, these voltages are sort of smaller than what we saw previously. These voltages, these spikes are a little bit wider, they're not as narrow, indicating that something's not right. Something is amiss. And so when you put these two together, the EKG, the chest x-ray, the symptoms that he's having in a pediatric patient, your list of diagnoses rapidly narrows down and helps you to focus on really what's the child's problem. It's not asthma, and it's not bronchitis. He has congestive heart failure for some reason. And so we can very quickly zoom in on that and try to understand it better and provide him the therapies that he needs. Well, this patient was getting sicker on us right there in the ER, so we admitted him to the ICU, the intensive care unit, where he shortly then developed respiratory failure. We had to put him on a ventilator, intubate him. He then developed into cardiogenic shock. That's basically a very low blood pressure. You're not delivering blood to the end organs like you need to. He started having arrhythmias, so little bursts of abnormal heart rhythms, electrical activity. VT, as someone had talked about, ventricular tachycardia. His acid level, his lactic acid level began to rise in his bloodstream. That's another sign that you're not delivering blood to the end organs appropriately. His kidney function started to drop off. His liver function started to be affected. And it was pretty obvious in a very rapid fashion that we were going to lose him if we didn't do something aggressive. And so, let me show you, sorry, here's an echocardiogram. This is a normal echocardiogram. This is supposed to be a motion picture. This chamber here represents the left ventricle, which some of you are very familiar with. This represents the right ventricle. And normally what you see is these walls here on the left ventricle moving like this. And we can measure how much blood is ejected with each heartbeat. Normally you eject about 60% of your left ventricular volume with each heartbeat. In patients who have myocarditis or heart failure, you're going to see a drop in that number. In this patient's case, his ejection fraction had dropped. You can see how dilated it is. His ejection fraction had dropped to 15%, markedly lower than what a normal ejection fraction is. And when you look on it on echocardiogram, it's just sort of like shaking or rocking. It wasn't even really squeezing. And you can tell then that the patient is in peril and something needs to be done quickly to save their life. In his situation, we implanted something called a Tandem heart. And this is a percutaneous device. It's a device that helps to rescue the circulation, basically. And what we do is we insert a catheter in one of the blood vessels in the groin. And this is the device here. We'll put it into the groin. This is in the inferior vena cava. We thread the device up into the right side of the heart, across a hole in the upper chamber, into the left side of the heart. I'll magnify that for you so you can see what I'm talking about. So the tip of this catheter then ends in the left atrium. And what we can do is we can evacuate blood from the left side of the heart through this catheter. It comes out of the body into this centrifugal spinning device, which then spins blood back into the aorta, which we have a catheter in. So you're basically unloading this left side of the heart. You're taking some of that workload off the heart and letting it essentially rest. You're supporting the circulation, you're keeping their blood pressure up, you're perfusing their organs appropriately, the brain, the kidney, and the liver, and you're resting the heart. And you can do this for several days. In this particular situation, we did it for 8 days. And this is what it looks like outside the body. And this is resting on his leg, and this is the device going into the vessels in the groin. And it actually sits there on the leg, and we have to stabilize it. And the patient remains sedated, giving lots of pain medicine, sedation, so he's comfortable enough in pain. And he's still on the ventilator respirator during this time. It was during this period that we kept a close eye on him, and we sent some additional testing. One of them was a test for a virus called RSV, respiratory syncytial virus. And we isolated this virus in his sputum. And we think that this was probably the cause of his deterioration. Which is not surprising. This virus loves to attack the lining of the lungs, and it caused a lot of the symptoms that he was presenting with. Wheezing, cough, sputum production. The scary thing is this is a virus that is very present. It's ever present. In fact, most of the people in this room have had this virus somewhere. I feel like I probably get it every year working in the children's hospital. But one of the questions we still have is, why are some people vulnerable? Why are they vulnerable at certain times in their lives to being ravaged by something that's seemingly innocuous and ever present? Well, we supported him, like I said, for 8 days. We treated him with IVIG. You've probably heard of that. A lot of people get IVIG when they present with myocarditis. And gradually, we began to see he had improved ventricular function while we were resting his heart. However, on hospital day 10, 2 days after we removed the device, I was in his room talking to him. He was lying in his bed, and his cardiac monitor starts alarming. And when we look at the monitor, and this is what we see on his EKG. So this has replaced those nice, narrow, regular spikes. This is a lot faster than what he had previously had, and it's a lot wider. It sort of has the sawtooth appearance, almost like a dorsal fin in a way. And this is called ventricular tachycardia. And the scary thing about ventricular tachycardia is that it can degenerate into this rhythm, which is ventricular fibrillation. And that's what happened to this patient in front of our very eyes. We're talking to him 1 minute, and he's unconscious the next minute. So we very quick. This rhythm does not have a pulse. This is cardiac arrest, and so we very quickly began CPR. We did CPR for about 1.5 minutes. We shocked him, and we got him back into a regular rhythm. And when we did that, he woke up, and he's talking, and complaining of a headache, and he had no idea what had just happened. So this is an example of some of the scary arrhythmias that can occur, and maybe an example of sudden death that we hear about in patients with myocarditis. Obviously, he can die with this. We can call this aborted sudden death, sort of a near-miss sudden death. But what this means is this qualifies him for a defibrillator. So we took him to the cath lab a few days later. We implanted the defibrillator, and he eventually went home on hospital day 24, and his ejection fraction had improved to 35% by then. We continue to follow him as an outpatient now. His last echocardiogram, I think, is around 50%, so it hasn't completely normalized, but it's really improved quite a bit from where he had been. And he's about to start college in the fall. So an example of a great story, that could have ended tragically, if we hadn't made it into the ER and been able to diagnose him as we did. This is his follow-up EKG, and it's back to those normal appearing spikes, more regular type activity. So I thought this was a good story to share with you because I think it illustrates a lot of the problems we have with pediatric myocarditis. One, it's difficult to diagnose. Well-meaning docs in the community, this was probably the only case this guy will ever see in his office. He may never see another case of this. They, kind of like what we heard, they hear hoof beats and they think horses. And so they don't think something that's so exquisitely rare for them to have walk into their office. It illustrates, I think, also some of our limitations with therapies. There still is not a really good therapy. It's mostly supportive therapies, like what we did with this particular patient. It illustrates how in some situations you can have return of function, even normalization of function. So I thought it was a pretty classic case that we could share with you. One of the frustrating parts of myocarditis is that we really don't understand the prevalence very well, in part because of our limitations with being able to make the diagnosis. Like we heard from somebody else, there's probably a lot of people out there walking around with episodes of myocarditis that go undiagnosed and we never even know about. So it's difficult to ascertain the true incidence and prevalence, and the diagnosis is often made on clinical grounds without a biopsy or ever even identifying a causative agent, a true organism, a virus or bacteria. This is a slide that looked at diagnoses for hospital admissions based on billing criteria. So it's kind of a crude way to look at diagnoses. But, and I'm not really interested in the absolute numbers, but what I wanted to show you was the incidence of myocarditis hospital admissions in children versus adults. In children, it occurs about 14.6 patients for every 100,000 children. In contrast, in adults, it's occurring at about 5.7 for every 100,000 adults. So almost 3 times more children are being hospitalized and admitted for myocarditis than adults. Again, just illustrating the difference between kids and adults who are affected by this disease. What are the symptoms? Well, we've heard a lot of them already. They can vary tremendously, however. Some people will come in acute cardiogenic shock, some with cardiovascular collapse and death. Others will have symptoms of acute heart failure, shortness of breath, fatigue, their ability to do exercise is now impaired, palpitations, chest pain, maybe vomiting and diarrhea in some of the younger kids, growth failure in the kids who have had myocarditis and heart failure for an extended period of time, history of a recent viral infection. Maybe they had a fever or runny nose or cough a few days or weeks beforehand. And some people can go on to develop chronic heart failure and come to us that way for the first time. Some of the signs, pulmonary congestion, we saw in that chest x-ray what it can do to your lungs, causing fluid accumulation in the lungs. Your peripheral tissues can also swell. We heard that already in the patient. A gallop rhythm, so this is a rhythm that sort of sounds like a horse galloping away. Instead of the normal lub-dub, 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 you hear a very sort of gallopy type sound when you listen to the patient's heartbeat. And you may have a murmur, a heart sound of a leaky mitral valve sometimes, and evidence of poor perfusion of blood to the body. So maybe their mental status is altered. Sort of, it sounds like that's what was happening with Paul. Low blood pressure, end-organ dysfunction, as you mentioned, kidney injury, liver injury, and even respiratory failure. Well, who gets myocarditis in kids? We see this sort of bimodal distribution. There's a peak early in newborns and infants, and then the incidence drops off for several years, and then peaks again in the teen years. And it was interesting hearing the story about testosterone, which made me think, this is a time of testosterone surge in boys. And I don't know if that has anything to do with it, but it's something interesting. And we do see more boys than girls affected with myocarditis. About 2/3 of our myocarditis pediatric patients are boys. What are the causes of myocarditis? Well, in pediatrics, it's mostly viral, almost always viral. I've never seen a case of giant cell myocarditis in a pediatric patient. I know they're out there, but it's exquisitely rare. Instead, what we see are these viruses more commonly. Viruses like parvovirus, enterovirus, which Coxsackie is in that family, adenovirus. I mentioned RSV, respiratory syncytial virus. Leslie mentioned influenza. Some of these other things can cause myocarditis. Sometimes, it doesn't have to be a virus. It could be bacteria, protozoa, parasites, fungus, even can cause myocarditis. And that's a list here of the many different types of organisms that can cause myocarditis, including streptococcus, salmonella, and then non-infectious things. Other exposures can cause myocarditis. We heard a little bit about autoimmune types problems with rheumatoid arthritis, rheumatic fever, lupus, scleroderma, giant cell, as we mentioned, Kawasaki's disease, which is a pretty uniquely pediatric disease, inflammation of coronary arteries. Still, we don't know what causes that, and a frustrating disease that we treat as well. Well, how do we diagnose it when a patient comes through? Historically, the gold standard for making a diagnosis of myocarditis is a biopsy, so an endomyocardial biopsy, a biopsy of the heart muscle. The use remains controversial still, and just because, as Leslie was talking about, just because you do a biopsy, that doesn't necessarily mean that you've gotten a piece that represents an affected part of the heart. And that's one of the problems with this procedure is you get a lot of false negatives. You can miss myocarditis a lot. This is an example of how we get a biopsy. This crude thing on the left looks like something from the Middle Ages. We insert into the groin vessels, thread it up into the heart through the inferior vena cava into the right side of the heart. And then we advance it up against the wall of the heart muscle, snap a bite of that heart muscle, and basically pull, tear it off crudely, and remove it. And we typically take about a half dozen samples when we do a biopsy. And we send it to our pathologist downstairs in the path lab, and they do a lot of stains for different things. And this is an example of what they might be looking at. So this is normal heart on the left. These pink striations are cardiac muscle, nice and organized, compact, looks pretty homogeneous throughout. And then this is an example of a patient with myocarditis. Infiltration with these blue dots, which are white blood cells, lymphocytes, actively going to areas of infection to fight off infection. And so this is what helps us make a diagnosis of myocarditis with a biopsy. Leslie mentioned that we're using MRI quite a bit more now, and we're doing that in pediatrics as well, particularly because a lot of our patients, you can't even do a biopsy. They're too small. You can't get catheters in their blood vessels. It's too dangerous. Their heart muscle wall is too thin, and you can easily perforate. And so we're sort of stymied, and we're hoping that MRI is going to be a good alternative for us. There still needs to be a lot of work done with research in that area to help us understand the utility of it, but hopefully it will help us. When we do an MRI, we're looking at some of these things that Leslie just described, areas of brightness or enhancement, that can help us make the diagnosis. Instead of a nice, how this all looks the same color, you can see some rings of enhancement in the heart muscle, indicating areas of inflammation. And in this slide, you can see how you can easily have patches. Here's a patch, here's a patch, here's a patch. It's not the whole heart that's affected. So you can imagine if you're doing a biopsy, you can easily miss a part of the heart that's not affected, giving you a false negative result. This is a slide I borrowed from Leslie. This is, I think, a landmark paper, probably the best review article on myocarditis that's out there, and I would recommend it. It's sort of doctor speak, and it's meant for a physician audience, but I think it could be also helpful for the lay public. And it's in the New England Journal of Medicine, published in 2009. It's nice because my favorite part is this graphic, and unfortunately it's not showing up very well. But I would refer you to this article because it demonstrates how this virus attacks the heart muscle, and sort of in two different phases you can have disease. The acute phase, damage is done by the virus and by the early immune response, and then subsequently a more acquired type immune response in which the body's immune system is really playing a role in ravaging the myocardium itself. It helps us better understand exactly why some patients continue to have symptoms of heart failure and don't really recover as well as others. What can we do to help our patients? Well, I described something that we do in pediatrics, which is basically rescue the circulation for the short term, to try to rest the heart, maintain blood pressure, perfuse the end organs, and allow some healing to occur for a few days in the short term, so that maybe we can remove mechanical assist and the heart will start to beat again in a more normal sort of fashion. We've done this with a lot of kids. In fact, about a third of our kids with myocarditis go on mechanical assist devices like an LVAD or a variation of it like that. And we published our results with this. In this particular paper, we talked about 16 kids who came in with bad myocarditis. They were in shock. We put them on artificial support, and we had pretty good results with them. 75% of them, or 12 of them, survived. They were able to come off support, and I think 5 of them went on to be transplanted, and 7 of them had recovery of heart function. So actually, a very encouraging story. Now, this next slide is a patient who has been supported with a different type of pump. And, so this patient is being supported on a sort of a larger variation of what I was describing, because she's too small to be supported with the tandem heart. So we actually had, our surgeons had to open her chest and put the catheters directly into the left atrium, directly into the aorta, evacuate the blood from the left side of the heart, allow the blood to be spun to the centrifugal device and sent back to the body where it can maintain blood pressure and perfusion to the organs. And this patient had a very good result and was able to come off this device after just a few days with big improvements in her heart function. I don't think this is going to play.
Yeah, it's a median.
Unfortunately, it's not. Okay, well, this was just another sort of short-term device that we're using in pediatrics now. It's a catheter that goes up the aorta into the left heart and evacuates blood. And it's an even smaller device than what we had seen previously. Some children, they don't respond well to short-term support. They have to go on to long-term support. Some patients, they don't have recovery of function, and they have to be transplanted. And so we do see that. And one thing that has been sort of a lifesaver for many of our kids is the advent of this new pump called the Braven Heart pump that was created in Berlin by the Germans, and they have vast experience with it. The U.S. is quickly gaining experience, and the FDA just approved this about a year and a half ago for the use in children as a bridge to transplant. So a lot of patients with heart failure, including myocarditis patients, can be supported and kept alive, basically, in a long-term situation while they wait for an organ. And this is just an example of what we're doing with it right now in pediatric patients. This is the smallest pump we have. This is a 10 cc pump, so that's 2 teaspoons of blood can be pumped out of the body and back into the body. And it's a pulsatile device, so the patient actually has a pulse. And we can get these patients off the ventilator. We can get them off their IV medicines. We can rehabilitate them, give better nutrition, get them stronger, and make them better candidates for transplant than they would have been otherwise. And this little guy is an example of that. Someone we've been able to make good progress with. He eventually went on and found a suitable organ. Here's just a couple other patients, just to give you a sense of who we're putting these in, the different sizes. These come in a variety of sizes. This is obviously a bigger size than the 10 cc. What about outcomes? Well, at 1 year, approximately, in kids, 30% have normal echocardiograms. About 12% have gone on to be transplanted, and about 2% have not. By 5 years, the numbers are about 60% of normal echocardiograms. So there's a really good chance that a lot of these patients are going to have improvements in their function and even normalization in their function over time. Well, in pediatrics, we like to have fun. It's sort of a touchy-feely, probably the most touchy-feely part of medicine there is the pediatric area. And so we like our patients to have fun. And one of the things that we've done is partner with Beaver Creek Ranch in East Texas with something that's called Hunt with Heart. And so these are ranch owners who like to hunt, they like to fish, and they have a strong feeling for kids who are suffering. So our cardiac patients, our heart failure patients, including myocarditis patients, you can go to this camp outside of Texas. It's several thousand acres, and it's stocked with animals. And they can fish and have a lot of fun and meet new people and commiserate. And they always have a parent with them. And right now what they're doing is it's only boys, and only their dads are going with them. But eventually they're going to have new living situations that they can have girls. They have a shooting range, so they can go and have fun and shoot. Like I said, they have live animals there, different types. They teach them gun safety. They teach them how to hunt, how to fish, how to do archery. And it is Texas, so that's... I don't know if they have this in Jersey or...
Not so much.
You don't do it on a ranch.
It's in the streets. So this is an example of a little guy with his guide and his dad, and some game that they. This is the guy on the left is our director of our heart failure program. I don't know what animal this is. That's just another example. And this is the dormitory situation, so they can stay there for, I think it's like 3 days is what they go for, and they have counselors there with them. Interestingly, we have a helicopter on standby, because some of these patients are waiting for heart transplant. So if an organ becomes available, we can whisk them away back to the medical center and transplant. And so a lot of memories are made in these situations. This happens twice a year that they can go and do this, and makes a lot of kids' lives a lot happier, at least for a few days. All right, well, thank you very much. That's all I've got.
Are there any questions?
Yes?
I actually have a question. Do you actually use ECMO too?
I'm sorry?
Do you use ECMO on kids too?
We do use ECMO. ECMO is a little bit more cumbersome than this other device I showed you that looks kind of like ECMO. ECMO has an oxygenator, so it can oxygenate the blood, it can remove carbon dioxide, but it's more exposure for the blood to have to pass through, and it's a higher risk of blood clots when you use ECMO. And so if our kids' lungs are working fine, we won't use ECMO, so we use this alternative. Yes.
It's known that myocarditis is killing more children and young adults than people believe, then it will not be a rare disease anymore, and it will bring a lot of awareness and therefore research money.
You're right. Well, you're right. It is an uncommon cause of sudden death in kids. Les showed a slide of Dr. Maron's paper on the athletes. I think there were only two with myocarditis in that cohort of patients, so it is uncommon. It may actually be, it probably is more common than we realize. One of the frustrating things, especially when a patient dies, is that, an autopsy may be performed, but maybe they're not looking at the cellular level and taking multiple samples of the myocardium. And I recently reviewed our experience at my hospital with myocarditis and autopsies, and I was really surprised at how many times they didn't actually look at the heart under the microscope. They just sort of did this macroscopic view, gross view. They weigh the heart. Oh, the heart's heavy, or the heart's thick. It has hypertrophic cardiomyopathy. But we know in a lot of patients who have myocarditis, the heart gets thick during this acute phase. When they're sick, it becomes swollen with cells, fluid. And so if you were to just grossly look at the heart, you could easily say, oh, that's hypertrophic cardiomyopathy. That's a thick heart, and not take samples of it. So that's, I think, the problem. So a lot of it is awareness. I mean, even in my own hospital with our pathologists, understanding the importance of looking vigorously and very closely.
And I might just add that one of the things we learned in the 1995 to 1997 giant cell myocarditis registry, when we got the samples in to review, and we had an independent expert pathologist review all of the heart samples for that study, a third of the samples that were sent in and read by pathologists as giant cell myocarditis were not giant cell myocarditis actually, but cardiac sarcoid. That in the broader community of patients, they actually miss the diagnosis. Board-certified pathologists miss the diagnosis of these rare diseases. And that's another opportunity for us. It's still out there. I can tell you this happens all the time. I mean, university medical centers will send me patients or cases. I'll get the slides, and I will read it differently than somebody who is local. It has some significant implications. And so having access to expert cardiac pathology digitally, we have the internet, we can send secure de-identified images, and having that available worldwide to people is critical to making this diagnosis. But again, many, many samples are not. We actually had over 200 samples, cases that were sent in for that New England Journal paper, but only 63 made it, largely because incorrect pathology, lack of pathology review, or the case, the clinical data was incomplete. And so, I'm saying, it's another opportunity. Yeah.
Yes, Ken.
One form of myocarditis that we haven't talked about today is a chronic form of myocarditis. We have seen some adult patients with a chronic pain syndrome that's continued, discontinued.
Yeah.
Do kids do that?
It does happen. It's very rare in my personal experience. And again, there's not much written on this in pediatrics. But every time we do a transplant, we take that organ out the patient has had, we've been living with, and we send it to our path lab to look at. And I can think of 2 occasions in patients who we just thought had run-of-the-mill dilated cardiomyopathy. It turns out that they had this chronic simmering myocarditis that had been there probably for months or years. It does happen.
Was the patient symptomatic?
Well, symptomatic with heart failure.
Yeah.
So
Okay.
what does that mean?
What does it mean?
Yeah.
My second question is, how do these kids fare psychologically after this major hospitalization, critical care?
Yeah.
How do they do?
That's a great question. Some of them do very well, but as you can imagine, especially in the patient who has a chronic form of disease, it can really wear them down. And so we frequently will get psychology or even psychiatry involved to help with these kids and their families. Sometimes it's not just the patient; it's the siblings and the parents. Almost like with a post-traumatic stress sort of situation at home. so the disease sort of infiltrates and goes throughout the family in a way, so at least psychologically. I've had a couple of patients who were suicidal, so we take that obviously very seriously. We are using antidepressants more frequently than we used to, and generally, kids 8 years and above, and that has remained a remarkable difference in some of these kids' lives. I used to poo-poo and dismiss the idea of antidepressants in kids, and I tell you, I have seen it work wonders in kids with chronic disease and change lives, maybe even potentially save lives. But it's real, and it can be a big benefit. Yes, ma'am.
Why did they do a drug test? Why did they look for pneumonia? Why did they look for a seizure if you're saying that his heart should have been enlarged based on myocarditis?
Well, not all of them are enlarged with myocarditis. I should say, preface that. Not all of them are. Some of them have normal appearing heart sizes with just depressed heart
So
function.
that's why they.
It doesn't squeeze very well, but it hasn't really expanded and dilated up.
That was just a minor question. But this is my question because when the medical examiner explained to me that he had a viral infection that caused his death, he explained to me that it was a virus that we all have that we may go to the bathroom a lot and that kind of virus. And that the white blood cells are what caused his heart to stop. So that's why I'm confused.
Mhm.
Is it the myocarditis that caused his heart? Or was it the white blood cells fighting off the infection in his body?
Yeah, well, the myocarditis you're basically talking about inflammation. And when you talk about inflammation, you're talking about the immune system and white blood cells. So it is the white blood cells. That's what the inflammation is. The white blood cells are circulating through our body and they sense a foreign invader like a virus or a bacteria, and they zoom in and they attack it and they try to basically rid it from the body. And what can happen is it can sort of be like a bull in a china closet, because the immune system itself can then sort of get a little bit reckless with the heart muscle and the rest of the body. And yes, the body's trying to fight off this infection, but also along the way, it can actually be tearing up the body in the process, the actual immune response itself. Yes, ma'am.
My son's autopsy report also listed chronic myocarditis, and if they mean chronic, does that mean he had it for years? And then it's kind of a part two question, because I'm friends with so many parents who have children the same age, so they're all a little freaked out about this whole scenario, at the fact that my son showed no symptoms and he died in his sleep. So if you have a child who has this, how can there be zero symptoms based on all the ones that you listed? So as an advocate for your child, as a parent, say he was sick 6 weeks prior, is there something that we can ask? Because they're 14, they're not going to know.
Right.
So can we ask them, do you feel funny? And what sort of things might they feel if they're not aware of what to look for?
Right. Well, Les, you could probably answer chronic myocarditis better than I could.
So, if your son died in his sleep, I suspect it was the pathologist who said that it was chronic.
Yes.
And they did it based on the histologic appearance of the heart showing some scar tissue or fibrosis, which suggests chronicity, because it takes weeks or longer for that to usually form. In the acute myocarditis, the acute inflammatory response, there's usually not much scar tissue. And then that develops beginning about week 3 or week 4 and can progress for a long, long time after acute inflammation. So in your son's case, I don't know the specifics obviously, but I suspect that it was conjectured that there was a older injury that led to some damage, and the damage formed a substrate for an arrhythmia that caused sudden death. I suspect, again, I'm just assumptions here, but that's the way the story played out. Remember what I said about we know a lot about myocarditis in animal models. We know very little about the mechanisms of myocarditis in humans. That's why the focus of our research is almost entirely on translating animal models into human disease and human findings into animal models. We try very hard in all of our grant applications to focus on translational science to make it clinically relevant. Remember I mentioned the smallpox vaccine? That's an experiment of nature, we'll call it, or biotechnology or corporate America, which is where millions, more than 2 million people have received the smallpox vaccination. And we know, since they're followed in the military, all of them, what the rate of smallpox, of myocarditis is following that defined. We know the day of the injection, and we know the day they get sick. And there are many we probably miss because they minimize symptoms. But in the 10,000 people we studied prospectively with day 10 blood tests to look for cardiac injury, 1 in 500 had a blood test that was abnormal, and 1 in 2,500 had a symptom like chest pain. 80% of the patients, or the military recruits, with evidence in their blood of cardiac damage had no symptoms in a prospective study. 80% of the damage is asymptomatic. And that is a sobering fact that myocarditis, we assume in virus injuries, is like this. Big assumption. But we can't study the time of viral infection because you're never there when the virus actually infects. You only figure it out when there's a symptom several days later. So we can't do that. We can't ethically infect people with viruses. But the military could give them this injury that caused reliably myocarditis. So we have the only human experiment that's ever been done that gave us prospective data on the percentage of asymptomatic disease. We also know, of course, that the patients in Japan with influenza myocarditis, that 10% had EKG changes or troponin rises, but only a small fraction had any cardiac disease, LV function, left ventricular functional problems. So large world of asymptomatic disease, small world of symptomatic disease. That's unfortunately the sobering reality, and there's a risk of arrhythmias in that asymptomatic population. It's possible that's where your son was. He was in that 80% who had no symptoms.
He felt nothing, not even a funny, fluttery, nothing that. So I can take home nothing to these parents.
So you can see the challenge for us as an institution in this room is that we're facing a disease that is truly silent for many people. If they have heart failure, like the patient Jack talked about, we know how to treat heart failure. We've got drugs and devices that can bridge people to recovery, and very often that is actually successful. It really works. But the greater challenge, because we have far fewer tools, is to identify people who have asymptomatic disease out there and to minimize the risk of sudden death there. That's truly a needle in an immense haystack, right? I mean, that frontier is almost beyond today's technology to approach. But we can get there. You got to start somewhere. We're here. That's going to be on the horizon.
I just had a question regarding troponin levels. At the point that it elevates, does it stay elevated, or is it kind of a bell curve as well? If there were damage that were...
Right. Typically what we see, and unfortunately we don't always measure it in kids either, but typically what we see is a spike at the time of presentation, and then a sort of a slow, gradual decrease in the troponin level during the hospitalization.
So to test healthy kids at a physical, you'd have to find that. If all kids were given the troponin test, you'd kind of have to be in that area where it was presenting.
Well, the thing is, if you're leaking troponin, you're probably sick. That's the thing. You're probably not asymptomatic. You're probably sick in a hospital, or sick at home. Those when you're starting to leak troponin, you're not just like going to school and regular day, that sort of thing.
So you would be presenting symptoms at
Yes.
that point.
Is there something that we could, as parents, ask during physicals for kids?
Well, I
Because
mean,
it's a basic physical.
yeah,
And the bottom line is if they put a little more effort into giving physicals to these kids,
yeah,
we would know.
yeah. I mean, I would certainly ask the usual type stuff, which for me would be, history of chest pain, palpitations, shortness
As
of
a
breath.
parent though, without having myocarditis, I would never.
But it's so
give
non-specific.
that to them.
It's so non-specific. That's the problem.
Just to add to that, before Logan passed, he had his 6-year annual physical just 2 days before he passed. And it was told by me, by his pediatric cardiologist, that had he done jumping jacks during that physical rather than being at rest, an irregular heartbeat may have been heard. So that's something that we in our community try to be aware of and spread awareness that when you have your child go to their annual physical, get them jumping up or doing squats or something to get their heart elevated. Because Logan's heart was 75% larger than normal, and he showed absolutely no symptoms whatsoever, and he died 2 days later. So is that a true thing to say?
Well, it's interesting that you say that because I do sort of the reverse. When I have a kid come to me with an irregular heartbeat, I have them do exercises to get it to suppress. As part of a routine physical, I mean, I guess it's pretty harmless and easy to do. I don't know how much flexibility on that, how helpful it actually is.
By the way, I didn't want to end what I said on a hopeless note, that we are promoting research to find these answers. It's just not this year that we're going to get those answers, but we get the beginnings of it. And as you can see, we're working on mechanisms of sudden death in myocarditis and specific targets that we could reasonably test for. And it's a long way to get there, but we haven't abandoned this. Our vision for our work comes from this room. Our goal of all of our therapy is to help people live longer and feel better. Only two things in the end.
All right, thank you, Dr. Price. Thank you, Dr.